Good morning. Thank you for the invitation. Like I mentioned, my name is Joseph DeMarco. I'm actually a radiology resident from Morristown Medical Center, and I'm going to present a case series of critical limb ischemia that was treated with isolated pedal loop angioplasty. These were performed at Holy Name Medical Center. So below the ankle revascularization is of great importance in contemporary treatment of critical limb ischemia. And to date, most studies have really focused on below the knee revascularization. But there haven't been independent studies on the isolated below the ankle revascularization. So I'm going to present a series of 14 cases between 2013 and 15 in which below the ankle lesions were identified and treated using angioplasty without any concurrent infrapopliteal or femoropopliteal intervention. So we identified 203 patients who underwent below the knee angioplasty between 2013 and 15 with Rutherford classification of 5 and 6. And we identified 14 patients, about 7% of the population, who only required the isolated below the ankle intervention, and that was treated with angioplasty. Majority of these were male, with age ranges from age 30 to 89, and the usual cardiovascular risk factors were identified with diabetes, hypertension, chronic kidney disease, including some patients on dialysis, as well as smokers. So I'm going to present an index case from our series. It's a 58-year-old male with past medical history of insulin-dependent diabetes, hyperlipidemia, and coronary artery disease, status post-coronary angioplasty 6 years ago, who presented initially with a slow-healing ulcer between the fourth and fifth toes. At that time, the patient really denied rest pain or claudication, but 3 weeks later returned, worsening pain, edema, and worsening ulceration. So on physical exam at that time, he had palpable femoral and popliteal pulses. He had a strong dorsalis pedis pulse, but only a weakly palpable PT. There was worsening edema, and as demonstrated in this picture, we see the ulcer between the fourth and fifth digits with an enlarging and actively foul-smelling exudate. So we performed transcutaneous oxygen perfusion measurements, which demonstrated the marginal dorsal foot to have decreased perfusion compared to an adequate plantar perfusion. So our pre-interventional angiograms show that there's nice runoff through the SFA, popliteal, and through the trifurcation down to the level of the malleolus. However, we notice that the lateral plantar artery is small in caliber, and there is an incomplete pedal loop on the plantar aspect. We do notice that there is a nice wound blush here. So for our intervention, cannulated the posterior tibial artery down through the common plantar to the lateral plantar and into the plantar pedal loop with a 2.6 French microcatheter and an 0.14 glide wire advantage. And we performed a 2.5 millimeter angioplasty. So post-intervention, we show that the lumen of the lateral plantar artery is significantly increased, as well as the flow rate, and we have restored patency of the complete plantar pedal loop. And compared to the wound blush that we saw in the initial images, we have an enhanced wound blush supplying that fourth and fifth intertriginous region. So our standard for the study was to perform a 6-week clinical follow-up, which showed very nice healing of the wound. So just to speak about the plantar pedal loop and what we do to assess. So we have the dorsal pedal circulation and the plantar. So the dorsal consists of the dorsalis pedis, which then anastomosis to the plantar pedal circulation through the deep perforating artery, and then that anastomosis to the lateral plantar artery and into the common plantar. So in our case series, there were 4 different types of interventions. The first being a dorsalis pedis intervention only on the dorsal loop, which is demonstrated here with angioplasty, a nice clinical result. The second was a plantar pedal loop, which is a majority of our patients, about half of the patients. And then there's also three cases of where the entire plantar pedal loop needed to be treated, which actually was associated with the worst clinical outcome compared to the others. And then there was other indications, including angioplasty of the metatarsal artery. So here's our 14 patients, and it was interesting to see that basically the angioplasty location pretty much correlated well with the location of the wound. And we have our angiographic success, which was defined as less than 50% residual stenosis, and that happened in about 64% of the population. Clinical follow-up showed very nice healing on the order of 80% of our patients, with complete healing in 5, partial healing in another 5. However, only 2 underwent non-healing, and they went to amputation. One of these was pre-planned intervention, however. And one patient ended up undergoing endovascular revascularization for subsequent SFA disease. So percutaneous transluminal angioplasty really has become the first-line management for patients with critical limb ischemia. And although below the ankle angioplasty has been described as a potential adjunct treatment to proximal angioplasty, it has not been described as an isolated cause of potential source of critical limb ischemia. So therefore, really 3-vessel runoff can't be used as the sole determinant for adequate perfusion and healing. Rather, you have to use your real-time angiographic analysis to identify any variations in pedal arterial supply, adequate integrity of the pedal arch, as well as identify these watershed regions such as the hallux and calcaneus. So in conclusion, below the ankle revascularization with angioplasty is technically feasible and associated with improved clinical outcome, whether that be primary wound healing or post-amputation healing. Real-time angiographic analysis should be used to assess the microvasculature of below the ankle and determine your revascularization target. An intact pedal arch has been associated with improved wound healing and higher patency rates. And close clinical follow-up is really necessary, focusing on wound healing and pain improvement instead of repeat imaging. Follow-up Doppler ultrasound may not be necessary or accurate due to the location of these lesions below the ankle. And one possible other way to follow these patients would be with transcutaneous oxygen measurements, which can indicate if prior and afterwards after your treatment, if there was adequate wound healing. Thank you.
All right. We have 3 minutes for discussion. Fadi or Dr. Plannert, anybody have a question for our presenter?
Yeah, just a very nice series, but I wonder how can you make sure that you don't intervene in just a spastic vessel? I mean, it's probably not the same pathophysiology or pathology as atherosclerosis. You have palpable pulses all the way, and even if you look at your picture there, it seems that you have, go back to the see the vessel is patent, just very small and maybe patent. So how can you I think that you have to make sure that it's not just spastic, and you know, post-intervention, it looks wonderful, but I'm not sure that the patient benefits.
Well, I think patient benefit is seen clinically. A patient had a wound that was non-healing, initially, treated with more conservative measures, and then when those measures failed and his pain was worsening, then you have to see exactly what is going on. And in this case, treatment resulted in good clinical outcome.
The short term, but did you use a vasoactive?
I'm sorry?
Vasoactive medication just to try to dilate the vessel before?
Just to dilate the vessel?
No.
Did you give nitro?
Nitro?
Oh, nitro. I don't think in this case nitro was given. In other cases in our series, we did give nitro. So that could be also, one of the issues is that there's some post-dilatation angiospasm too in some cases. So our technical angiographic success may not have been as high in those cases. But I think, again, the clinical outcome was rather good.
We do have about 10 to 15% of our patient population in our center that have what we call end-stage tibial disease, which is plantar disease. The pictures that I use showing right now, when you look at these vessels under ultrasound, you can clearly see the medial calcification extending all the way below the ankle. Actually, they have preserved tibial flow. And I know, George, you do this in your practice. We do this in our practice. Actually, we try to modify the vessels with atherectomy. There's 2 devices, maybe 3 devices on the market that you can at least, and then recreate that pedal loop. But these patients are the most challenging out of all the patient population that we have.
And I think this is a great example. You mentioned the vasodilatory effect, et cetera. Is it spasm or is it not spasm? A lot of these cases aren't spasm, especially if you've not manipulated the vessel distally. So I think you did the right thing in terms of making a larger lumen. I think this is a great example of improving perfusion pressure. Even though you have a patent lumen, you need that perfusion pressure to heal the wound. And the goal of therapy is to heal the wound. Actually, in the future, if we probably looked at this a couple months down the line, I would imagine that it would have reconstricted. But as long as you've healed the wound, I think you've done your job.
I think it depends, too, on the watershed regions that you're saying and variations in the supply where you may think that, in this case, the posterior tibial would be your main source, but that giving that adequate supply from your anterior distribution improves your healing as well.
And if anything, this speaks to the limitation of angiography, right? And you touched on that a little bit. This really speaks to the limitation of angiography in evaluating the response to treatment with CLI patients. You can't just depend on that.
As a final question, given that it's an outflow termination type of thing, despite the redundancy of the circuitry, anterior and posterior circulation, do you find 7% at 112 days of reintervention to be a low number, high number? Do you expect it? What do you think about that?
As far as the reintervention rate you were speaking to?
Yeah.
I think, again, we use that six-week clinical follow-up to give the patient time to heal. And out of our whole entire series, which is not many patients, but only one ended up having reintervention, and that was for a different reason besides what we saw in the plantar pedal loop.
All right, thank you very much. So as it is a face-off between the two, with respect to the type of case, clinical presentation, and the use of those cases in your own practice, let's have a show of hands for Dr. Amico's presentation and the audience awareness of that case, and for Dr. DeMarco's presentation. All right, so Dr. DeMarco, fight to the finish. I guess you win that one. 2 excellent cases and an excellent session. Let me break now for our lunch session, and we'll see you guys back after lunch in about 45 minutes. Thank you very much.